Doctors have gotten a raw deal in terms of technology. We know that. All of the previous speakers have talked about that. And I think doctors have missed the boat to really make EMR what it needs to be to help them deliver better care more quickly with less effort. Because that's fundamentally what I think the purpose of technology for doctors is. But there's a new way of technology coming in, and that's artificial intelligence. And I want to offer a solution for how doctors can be a part of that wave and be a stronger advocate for influencing that technology so it serves the purposes of both doctors and patients first and foremost. My name is Dave Prakash, and I'd like to ask you a question. How do you know you're in the same room as a pilot? Don't worry, they'll tell you. So I spent 12 years in the Air Force working as an operational test pilot for nuclear bombers, and split my time with that and working as a flight surgeon as well. I was originally a physician. About 20 years ago, I decided to serve and left a career in anesthesiology as a resident to join the Air Force. And in my time in the Air Force, I learned a lot about how to make aviation systems better, so that how can we make it easier to operate and more accurate and survivable for the pilot while making it more lethal against our adversaries. And I feel there's a lot of lessons there for how we approach the integration and development of new technologies in AI. Now, I need to also add that I do have a financial relationship with Anthem as an employee, but there was no commercial support provided for this activity. After I left the Air Force just a few years ago, I went to business school, studied public policy, and now work in healthcare AI-based technology. I'm really talking about technologies in computer vision, natural language processing, and machine learning. And what I want to start off with is giving you just a lay of the land and some of the opportunities that I see with AI and technology in healthcare, and also share some of the implications, and then get to what I'm proposing as a solution to help doctors have a more active voice in this world. So clinical decision support. I think it's a great way to take out a lot of the trial and error in the management of chronic diseases. I mean, we know we have an algorithm we follow, and we try first-line therapy, second-line therapy, and in the end, what we're doing is wasting a lot of time, and our time, the patient's time, and also exposing the patient to a lot of harmful, ineffective medications, and also wasting time where the patient is marching towards all the complications and comorbidities of that disease. And so I see a lot of tools coming down the road that are going to remove a lot of that trial and error process. And this gets to the concept of precision medicine. We know the Inuit Indians that live in the Arctic Circle have a diet of 90% seal blubber. They also have a genetic mutation that's optimized them to survive on that diet. So is the Mediterranean diet really the best diet for them? I would argue it's the best diet for the most number of people, but there's probably differences as far as what's the best diet for you and what's the best diet for me. And I believe technology and nonlinear data analysis is going to help us get there. And the other opportunity here is help us identify and measure our own outcomes. When I flew the jet, after every sortie or mission, we spent an hour and a half talking about who was 10 seconds late to the target, who was off altitude, who missed a radio call. And all of that was done to make sure that we knew what we did wrong on that day so that our next flight was that much better. And here's an opportunity with technology to help physicians look at what their last 100 patients were like for a particular condition, and what are they doing, what can they do to make it better? Because when we look at the guidelines, when we look at clinical trials, it's based on a certain subpopulation, where that trial was done. And that may not reflect all the differences in our particular area. In 2017, I was in Louisiana. That was my last assignment base. And I can tell you there's a lot of differences in terms of the prevalence and incidence of different diseases. And you look at the social, cultural, economic differences between that and California. And I think those are all relevant issues to bring to bear in the delivery of healthcare. And I believe some of the AI technology that's in the pipeline can solve those, fix those problems. But it also brings a lot of risk with it. And this is where I feel the medical technology world has a lot to learn from the aviation world. There's a whole discipline called human systems integration. And that's really what I focused on, how to make the system adapted to the operator instead of making the operator adapt to the system. I love engineers. They make great things. But when they don't understand that when I'm flying the jet, I've got an oxygen mask, a helmet, gloves, I'm strapped into an ejection seat, and I got the ground control, my wingman, and another controlling agency talking to in my ear all at the same time. The last thing I can do is have to do 20 button clicks to target a weapon. I need it to happen in 1 or 2 clicks. And that's the parallel here with aviation. And so we've looked at human factors. We've looked also at the risk of automation, complacency, and halo effect. And I'll get into that a little more. And this also, on the policy side, brings up some issues with liability. When we have clinical decision support tools that give you the wrong answer, and because you've become accustomed and confident in the system and you go along with it, who's to blame when something goes wrong? What about the other way around, when the machine is right and you apply clinical judgment and decide, you know what, based on my experience, I'm going to do something different, and an untoward patient event happens? Who do you blame? And the legal circles are debating this. You know, is it product liability? Do you blame the manufacturer, or do you blame the operator? And that's to be determined still. And let me talk a little bit about how this technology is going to affect clinical research. Right now, the whole concept of translational medicine is pretty hot, and the process from a new innovation to changing clinical practice takes about 15 years. And it starts with a doctor with a hypothesis, does a pilot trial, gets some positive results, you get some more money, you write some grants, and you're able to do a larger trial, and hopefully you can publish in some important journals. And eventually, you hope it can get into a review article and in the hands of a med student somewhere 15 years after the fact, and maybe, just maybe, it'll get into a guideline. Well, I think 15 years is too long. And so real-world evidence, it gives us an opportunity now to look at enormous data sets that span the entire country and let us do essentially a meta-analysis on the wild-type population from day one, looking backwards 6 months, a year, whatever's necessary to get that statistical power. And I also add not just real-world evidence, but real-time evidence is the other term I'm thinking about now. Again, if I can see exactly what's happening in my patient population in the last 2 months, I'm more apt to change my behavior. And in the interest of time, I'm going to cover this a little later in the next slide, actually. And so what I'm proposing, so now you get a sense of what the opportunities are with the technology. How can doctors play a bigger role in this? Just sharing another pilot story. I was always frustrated with the design of our avionics, our aviation software. And I remember we went to a meeting with a defense contractor, and I spent a week with the software engineers that were building the systems that we were going to be using in the jet. And we just were frustrated. Like, this isn't what we need at all. And the engineers were frustrated. You know, why were we criticizing what they were building? And it wasn't until I decided to take them out to lunch, and ended up taking them out to dinner a few times and having a few beers. And at the end of that week, one of the software engineers got up to present his mock-up for a module that was going to go in our jet. And he said, you know what, I spent a lot of time talking with the pilots last night, and I'm going to put this mock-up away because this isn't what they want at all. I need to go back and come back this afternoon. I'm going to give you, I think, what you really need. And that's an example of where the parallel here is, how can doctors meet engineers where they are, and vice versa. And so what I'm suggesting is journal club for AI technology. You know, we've looked at, you know, all of you have been to journal club. You know, it's where you look at a paper and you're taught and you're trained how to critically evaluate how the study was done, what was the analysis and statistical analysis done in that, and then finally, is this solution valid? Well, I think doctors are going to have to now apply that same concept to a lot of the clinical decision support tools that are coming their way. You know, I shared some of these amazing opportunities, and I think anyone that's selling you these technologies is going to talk about just that. But they're not going to tell you about some of the deficiencies and risks in these technologies. And just like we've all read articles that make headlines, and then you get into the article itself and you realize, this is bunk. I'm not going to use this at all. And that's where I think doctors need to go. So let me just go through what I think are some of the topics that doctors need to understand as they're evaluating clinical decision support tools. The first one is off-label use. And to help you understand what I'm talking about here is, there's a concept in data science called the law of large numbers. Whenever you add more data, the model you're building is always going to get better. But the fact is, the model's not going to get better for all of the subpopulations equally. And that's a very important distinction here. And so when you have a clinical decision support tool, you need to be able to critically evaluate what was the data set that it used and how is it performing on other data sets, and figuring out, is it appropriate for your patient population? And let me jump to bias next. This is a hot term with the Optum algorithm, but it's a little more complex than just discrimination. To a data scientist or an AI engineer, bias is not good or bad. It's really a function of overfitting your model. That's all it is. When you overfit a model, what you're doing is putting too many constraints so that if you have a scatter plot, all of your data points are concentrated. You know what, better example. Imagine that round circle is a dartboard and you're shooting darts. If you have high bias and you're overfitting, all of your darts may be landing right here. Very precise, very tight clustering, but not at all accurate or close to the target. But it may actually be overperforming for a certain population that sits in this area. Now contrast that with variance, which is underfitting. Imagine you have the darts going across the entire board. The average of all those positions is pretty accurate, right? But perhaps it's not performing to the level you need it to perform for your particular patient population. And so these are concepts that I think are important for doctors to understand. And then I'll tie that into bias as we know it. And I'll share what happened with the Optum algorithm, this discriminatory practice that technology created. Bias, it's in the form of, it's baked into the data, how doctors have historically practiced medicine. When you talk about women with a certain cardiac risk not necessarily being sent to the same cardiac workup as a man. There's also bias in the algorithm itself, whether it's overfitting or underfitting. And then finally, in the feature engineering, the proxies that you're selecting. To help you understand that last point, when I say proxy, I'm talking about race. It's really just a proxy for genetics, right? And what happened with the Optum algorithm, they were looking for a proxy for medical severity, and they chose cost of care. The problem is they didn't realize that access to care influences cost of care. And so you had, for a given score in this algorithm, a white person, or a Caucasian, who has more access to care, would spend more money, and therefore have a higher cost of care, and would appear to have a higher medical severity than someone African American who doesn't have access to care and therefore spends less, but may be much sicker. And so the conclusion of that article that came out in October in Science just last year was that we need to be careful how we pick our proxies, and instead of cost of care, maybe comorbidities was a better proxy for medical severity. And so I offer that as another thing that I think physicians are going to have to critically evaluate with the technologies that are going to be put forth. The next one is correlations and causal inference. And this has a little bit to do with explainability, understanding what why the system came to a certain conclusion. Correlations. I think the perfect example of this is an old study that looked at outcomes for patients admitted to the ICU with pneumonia. Patients who have asthma turned out to actually have better outcomes when admitted. And so that complicates things. But it's a valid correlation. The fact is, if you have asthma, the data show that they did better. The problem was, if you have any one of us in the room who's a clinician could have easily figured out, well, of course, it's only because someone who reports they have asthma and goes to the ICU with pneumonia is going to be treated more aggressively or sent to the ICU sooner, and that's why there was better outcomes. And the risk is, for someone that doesn't understand that, is that, oh, you have asthma? I don't need to worry about you. And you can see how that can influence the outcomes. And that gets into causal inference. We need to draw a difference between correlation and actually having causal inference. Supervision level, when you're working in a large healthcare system, they're looking about economy. And so when you have a clinical decision support tool that's designed by people who are thinking, hey, a doctor's going to be supervising this, what happens when you push it to a mid-level? What risks are now going to be at play when someone who doesn't have the same breadth of experience to be able to override some of those decisions? So think about that. And let me get into Human in the Loop. I think this is going to tie into a lot of the opportunities and issues that I learned in aviation. When I'm flying in the jet, and I've flown with astronauts, I've flown with people with 500 combat hours, and guess what? I'm a little less reluctant to speak up if I see them doing something differently. And it's not unlike any of us who've been in the OR as a resident, and you're with the chair of the department, and maybe out of the corner of your eye, you saw them move their hand out of the sterile field. Who amongst us is going to raise their hand and go, sir, I think you just broke the sterile field? You're going to question whether or not you really saw that. And so that's one aspect. And so with clinical decision support tools, as we become more confident and start trusting of these systems, how likely are we to stand up and say, no, I think I'm willing to spend the extra time? Imagine at 2 in the morning or 6 in the morning after a long ER shift in the ED. How likely might you be to just say, you know what, this is what the system said, I'm going to just go with it. And these are the human factors that I think are missing in a lot of the discussion about technology today. And this has all been borne out in the human systems integration discipline in aviation for years. Another example is automation. When you look at getting used to doing things a certain way, in the aviation industry, we've seen this with the autopilot systems where pilots were so used to letting the machine do it, when they saw the machine deviate, because the frequency of interaction had gone down, they were less likely to intervene when intervention was necessary. Now, I had the benefit of a really old, archaic autopilot system that tried to kill me on a weekly basis. So when the plane started rolling, I didn't even think twice. You take the jet and fly. But I can see a time where a lot of the mundane decision-making processes become so frequent, so accurate, that we may miss some of those really big consequential decision points. All right, so this is my framework for this idea of journal club for AI. And if we have a good clinical decision support tool that can integrate all of these new disparate data points, like genetics, imaging, social determinants, the other key drivers, and financial well-being, to help doctors make decisions that are well beyond the ability of human cognition to do so, I think it's going to be a brave new world. But there's one last point I want to just share with you. Today, doctors were quick to want to come to a diagnosis. What I mean is, if we have a suspicion of a disease, we order a test. Was the MRI positive or negative? No? All right, maybe I need to get a blood test. Was that positive or negative? We're in a hurry to get to the diagnosis. With these emerging clinical decision support tools with AI that are integrating all these new solutions, I'm suggesting that doctors need to learn to be more patient. Because when we're able to integrate, we need to look at, for example, a genetic test, and there's a positive mutation, but I don't know what to do with it. Be patient. Think about what other data sources, think of it as just one pixel in a larger mosaic. And when this new AI-based technology is able to integrate all these solutions, maybe you're able to get a much different picture of what the problem is. So this is down the road, but I think we need to rethink the whole thought process in diagnosis and therapy selection. Thank you.